from breakthrough strategies to game-changing innovations and cultural shifts. You'll discover the lessons that drive real impact, and we'll dive into the moments that changed everything. Welcome to The Missing Piece with April Reed. All right. Well, I'm excited. Welcome back to the Missing Piece podcast. Today, we're joined by Dr. Lisa Birdsall-Fort, Assistant Chief Medical Information Officer and System Chief Officer over Ochsner's Virtual Care Center, as well as Senior Emergency Medicine Physician and Medical Director in New Orleans. With advanced training from LSU, Columbia University, and a Master of Public Health from Tulane, Dr. Fort sits at the intersection of clinical care, technology, and digital innovation. Her work strengthens patients' access, improves care delivery, and supports providers on the front lines. Today, we'll uncover the missing pieces shaping the future of emergency medicine and virtual care. Please welcome Dr. Lisa Fort. Thank you, Lisa, for being here. I'm really excited to hear. So to get us started right away, who is Dr. Fort? Who are you? How did you get started? Tell us about you.
Well, first, April, I'd just like to thank you for having me on. I think this is a really great program and I'm excited to be a part of it. So appreciate the invitation. So I guess my origin story is I'm from a very small town in Bayou Country, South Louisiana. My father was a family physician. My grandfather owned a small pharmacy there. And so I grew up sort of with medicine in my backyard, but wasn't sure that's what I wanted to do. And when I finished college, as a matter of fact, I originally went to public health school and got a master's in public health and health systems management, thought I might go in that direction. But what I found was my favorite part of that time was the interactions I had with patients as a part of that training. And so it really brought me back to the bedside and really understanding that was kind of my mission and my passion, is that I wanted to be able to do that. So I went to medical school here in Louisiana during Hurricane Katrina, which was an incredibly transformative time in healthcare here. Of course, with great challenges come great opportunity. And I think you need to always have the mindset of learning from those experiences. And so then I decided I wanted to do emergency medicine directly because of the immediate aftermath response of Hurricane Katrina, and working with a couple of amazing ED docs that I thought just could do anything. They're heroes in white coats. And so I was like, that's what I want to be like. And so ultimately went up to train in New York City and spent several years there. Worked up in the Bronx following training, but decided to come back home because I really wanted to reconnect with my community and take care of the people that I was closest to when I was growing up.
Incredible story. I'm sure your family's excited. Have you been able to practice alongside your family at all, or?
Yes, to a large extent. And as a matter of fact, that's even kind of gone on to the next, I would say the next generation in a sense, because I have several cousins currently in training, and my brother is married to a resident at Ochsner. As a matter of fact, right now she's an anesthesiologist. My sister's an anesthesiologist, so definitely fortunate. And then even outside of just physicians, having people, my brother is actually training as an occupational therapist, and that's a really special part of this. And also just my dad's legacy at my own organization and meeting people that he worked with for a long time and being able to maintain, I think, a piece of him within my work.
I love that your story not only is, from your roots, but it's obviously because of the passion led by, what you've seen, then what you experienced on the bedside, to then being a part of even the Katrina. I love what you said. Doctors were the heroes in the white coats. To a student that is having that desire, they see physicians as the hero, but they think it's the unachievable. Like, what would be your advice to the student and or the one that's questioning, is this for me? You've got to be. And did you ever have those questions along the way when you're in New York and you're studying, you're like, okay, I'm really not sure if this is for me?
Yeah, I think the first thing is, like, you don't just get one shot at this stuff. I mean, that's part of what I think you learn and in your own growth and development track, is that you don't necessarily have the ability to plan what you're going to be 10 or 20 years in the future. You have to sort of figure out what the most important things are to you and be able to continue that thread throughout whatever you may do. But I think what's interesting to me is, even going to a public high school down in South Lafourche Parish, a lot of what people thought was success was just basically you have to be a doctor, an engineer, or a lawyer. There are a million things out there, especially in our age of, technological advancement, that I think people need to think about being exposed to. And the corollary to that is that we have unprecedented access to what that looks like. You can get online and get on ChatGPT or Open Evidence or whatever it is, and it's very different from a Google search and reading a synopsis of what a job looks like. You can have a whole conversation about what that day to day actually looks like, what part of you is reflected in that type of work, what different directions you could go in with it. Um, I'm always surprised by how much we just learn on the go, but at the same time, I think that we have almost infinite capacity to explore it now without having to commit. So I would say just identify what the things are that you feel like you want to be able to accomplish with your life, with your career, how to appropriately balance that with things that are most important to you in your personal life, and go for it.
I love that. Great advice. So let's talk about your role currently. It sounds like you're wearing a lot of different hats from being a physician within the emergency department, overseeing the virtual care center. Tell us more about your role, your day to day life at Ochsner.
I think emergency. So I'll say that my best job is still being an ED doc. I love working in the emergency department. I feel like I always say it's about quality over quantity of time because you do have a really important opportunity to interface with people and sometimes one of the most pivotal moments of their life. And so I think it's important to be able to create a connection and guide people to the right decisions they need to make them feel supported. You don't have longitudinal relationships like primary care doctors do or cardiologists do with patients necessarily, but you do have to really be there for a patient in that critical moment. So I still get a lot of satisfaction from that as well as the team. ED nurses are amazing. They can do anything. It's pretty fun. We're very shoulder to shoulder. And so the camaraderie is definitely a big piece of what's wonderful. And, when you have a really, sick patient, you have to pull together and sort of act in concert, almost like a SWAT team to just kind of jump in and do what you need to do. And so I think that's really satisfying work. But ultimately, what I found was, my work just purely clinical when I came out of training was wonderful, but there were things that I saw that needed to be fixed. And I needed to gain insight on how to start to go about that. And so my first leadership role was as a medical director of an emergency department. So I did operations for many years and have been a medical director over a series of EDs. And then from there, went from just what are the mechanics of getting patients seen, getting them their tests that they need, getting them in and out, and those types of things to how do we really shift to delivering the top quality care that we can for patients? And so that really got me interested in standardizing and building workflows that support quality. My first major focus on that was with sepsis, this was now 10 years ago. I'm sure you know that sepsis is the number one mortality driver, morbidity driver in the hospital. More patients die from sepsis than anything else. And so creating standardized systems, whether that be documentation or order sets or easy to access antibiotics or all those things, I think help to deliver that care in a rapid fashion, which is really important in that disease state. But then you can imagine that can also apply for things like stroke or trauma or things like that. And so I spent a couple of years really trying to train up my quality skills, whether that be through Six Sigma and program management and project management, just really understanding what quality measures are for hospitals, what hospital-acquired complications and infections we may be able to influence by really standardizing and improving workflows. And then from there, I figured out that you can't do any of that stuff without informatics. So during COVID, we all had kind of a crazy time, but was spending a lot of time at home that may have been spent other times in restaurants or traveling or what have you. So I decided to get board certified in clinical informatics. And so did a practice pathway for that. And that's how I got into the informatics side of things. And so it's all been wonderful. I feel like there's little pieces of it that always thread together, but that was really the story of how I got from point A to point wherever I am.
I love this. I mean, I love that you're a lifelong learner. I love the ambition that you have because I can tell that it's coming from a place of truly caring and wanting to make a difference and have an impact and not just this is what I do. And, like I just have to go to learn, get an education to, whatever. Like you're doing it from purpose. Like everything that you're doing is from a place of purpose. Let's talk about technology for a little bit because as I mentioned, I've been implementing and training EHRs since 2004. So here we are 21 years into working with electronic health records before they were ever a thing. I originally was on the Department of Defense rollout, and then until, it took gangbusters. So you've been obviously on this journey of not only EHRs being put in, all the changes when it comes to the applications that support you to do your job. Talk to me about that. Good, bad, indifferent. Now you have a degree in clinical informatics, which is awesome. But yeah, just give me your thoughts.
Yeah, the way I think about this a lot is I think there's kind of three facets. I think there's people, there's process, and there's technology. And so, I went from a time when we still had paper medical records through all of medical school, most of residency training, that was still sort of the standard. And really got to see meaningful use come in. And I was a major proponent of it from the very beginning because, when I was seeing patients in the emergency department in New York, let's say it's somebody that I knew had been admitted the week before, perhaps because I admitted them, to be able to obtain those medical records, even from just that one hospital, required somebody to get in a car, courier across the city, go to a warehouse somewhere, grab a stack of, however many charts. I mean, tremendous amount of data loss. You would see papers hanging out of it. Obviously couldn't read people's handwritings. My own handwriting's awful. I was a very early adopter of typing of everything. But at any rate, just that was like a pretty clear, obvious need to me. And then beyond the four walls of an independent organization, being able to share and recognize information across different care areas, whether that be clinics or other hospital systems, et cetera. So I mean, just from like I would say an access to information standpoint, it was immediately apparent to me that that was the direction that we needed to go. But then I think that there's only so much you can ever build in terms of things like clinical decision support or standardized processes. I think the people part of it is, sort of getting people to transition from writing things and checking boxes and having pretty limited information, and pretty non-standard information into inputting information. Now, I think we ran into a big challenge with that, with the people and the process and the technology fitting together because, as you know, many of the things we do from an EHR is create a record that we can bill for services. And that's not always clinically meaningful. And that's not why people wake up and get out of bed in the morning, is to put together, a list of services that we're going to then transition over into some sort of payment model. So I think that really created a divide. And, I'm not unique in this thought, but I think that was definitely something I experienced firsthand, seeing my attendings and then my colleagues having to move from what they were comfortable with and kind of what they had made work in their careers to this new world order, and having to face away from their patients and have their backs to the patient and frustrations with workflows and those types of things. So what I see right now with the advent of AI is truly a restoration of trust between the people and the technology. And I think that we're seeing that at a scale and a speed that's absolutely astounding and tremendous. And so I like to use the word metamorphosis a lot because I don't think it's just about care transformation. I think it's completely reworking the way that we're going to take care of people. And so it's not just, sort of taking a caterpillar and making a caterpillar go faster. It's turning a caterpillar into a completely different organism, but it has the same DNA. And so just helping people to understand, like, this is how we can, get you off the ground and fly to take care of your patients. And we're going to do it with you this time. We're just not going to sort of impose something. It's going to be much more focused on a co-development mindset. And we're able to do that because we have access to artificial intelligence today.
Yeah, that's amazing. So I do want to talk about that. I love the way that you position that because EHRs were forced. Even if it was incentivized through the meaningful use efforts and the measurements, it was forced. It was
Hmm.
like, we're no longer on paper. You have to go do this. And the physicians weren't invited to make a decision, let alone do something when their specialty, and especially the emergency department. I remember it's like, how do you expect us to save lives and then spend an hour, in the early days, documenting the life that we just saved or what we need to do. So, and obviously now we've all adopted EHRs. It is what it is. And here it is. And now it's the AI wave. So now here we have artificial intelligence. And even though we've been talking about it for the last 10 years, it's here. And the impact that it can have in an incredible way for healthcare is exciting. And Dr. Ford, as you and I talk, we see it because we've been in the technology space. You've studied it, you've done it, you've been alongside of it. However, there's, I would say it's 50-50 split. A lot of people are not excited about it or see it as the way that the physicians originally felt when EHRs were introduced.
Hmm.
What, what are your thoughts on AI where it is today, where it's going, and where it is going to impact healthcare as a whole in 1 year from now. We don't even have to say 5 years from now. It's literally
Yeah.
1 year from now.
Yeah, it's hard to even say 1 month from now what it may be because of how rapidly this landscape is changing. So I think we need to learn from our experience over the past decade. Yes, we knew this was coming. Certainly AI is not new. It's just enabled now at a completely different pace than it was previously. And so I think we need to make sure we do partner with the bedside and how they do their care. And then I think we need to also figure out ways to be able to shift some of the meaningless tasks kind of work into an automated space so that we allow people to connect to their purpose for, again, why you get out of bed, and go take care of patients every day. So if a nurse is able to walk into a room and have a deep thoughtful conversation with the patient and their family about what's going on with them, as opposed to having to click a button about whether or not the patient's been turned, whether or not they have a catheter, whether or not they receive their medications, if we can just sort of capture that information from the environment, whether that be through a camera enabled with AI, ambient listening, through RTLS, and all those technologies that we have available to us. I just think it hands the human connection back to the people who are really, really good at that. And that's why they do this in the first place. So I think that we need to be able to tell the story in that way. And it's going to give people faith that we're doing it for the right reasons and not because we want them to take care of an extra 10 patients or something like that. And so I think we need to be really cautious about that. Sure, are we going to increase people's productivity through these things as an absolute output? I think that will happen. Is that why we're doing this? Is that why I do this? Not at all. It's to be able to improve the way that we take care of people.
Here.
And so I mean that kind of leads into some of the virtual discussion, I think. So
Yeah, that's what I was gonna ask you about. You're over the virtual care center. Have you guys always had a virtual care center, or is that new within the last few years? Or tell me the evolution and how did you get involved with that?
yeah, absolutely. So it is relatively new. And so I would say, we have several pretty mature programs right now, one of them being our virtual nursing program. And so we have sort of a centralized team of nurses, both critical care nurses and nurses that are more focused on like med surg type patients. And the critical care nurses help us to sort of, I call it the nurses in the sky, the eyes in the sky. Anytime there's some sort of, if there's a patient, they jump in, they help with documentation, they say it's time for epinephrine, they help to augment the care team by helping to provide some of that direction. But they also provide procedural support, they do quality rounding, they do proactive rounding for patients with elevated risk scores based off of machine learning models that we have in place so that we can be more anticipatory about what patients need instead of reactive. And so that's a huge area of support and resources that we have. And then our med surg nurses really focus on the function of getting patients in and out of the hospital more efficiently. And so I don't know if you've seen a nursing assessment recently for the things that need to be asked when a patient's admitted to the hospital, but it's voluminous. And a lot of it, if it's not relevant to that patient, is just really paperwork and busy work. And so by allowing, a virtual team to come in and take some of that work away and focus on it and really do reps of the same thing over and over, it allows the bedside to focus on the care they need to provide. And then same thing with discharges, the we see, things that happen all the time with care plans that don't get executed because patients didn't understand them because the person who needed to spend time and really explain it didn't have that time. And so, let's say a patient was supposed to be prescribed an anticoagulant, but for whatever reason, it didn't end up on the medication list. It's a place where really, a focused eye can pick up those things and make sure that we take care of it. So that's one way we use it. We just recently, in October of last year, also put together, I think, a relatively unique concept called a virtual emergency department. We call it OVED for Ochsner Virtual Emergency Department. And so we, as emergency physicians, receive messages. We do it all through our EHR. And we receive messages either from clinics or urgent cares or our nurse on call triage line. And we're able to just help them to take a look at whatever the patient's need may be. If the patient has to call 911, then they do that. But otherwise, people have a really hard time navigating what type of care they might need. I think patients are not great at self triage. They don't have the objectivity to do it often. So, do I need to go to urgent care for this problem? Is this something I can wait 3 days for? I think most people in healthcare get these text messages from their friends and family all the time. And so it's a way for us to be able to provide that type of, personalized kind of concierge expertise to everyone. And we're able to divert patients from expensive care and alleviate some of the overcrowding that happens in emergency departments by helping them go to alternate places where they can get that, even in a virtual sense. So those are a couple of examples of how I think about it.
That's incredible. What EHRs have you been exposed to? And then do you have different EHRs for like the emergency department and then the virtual care center and then the acute care side, the ambulatory side? What EHRs have you used?
So Ochsner is an Epic EHR customer. We were very, I think, early adopters on Epic. 2012 was our initial go live, and we've been very intentional that we wanted to be on a single instance, regardless of what hospital systems we acquired or brought in, what clinic groups we work with, et cetera. It allows for us to be really standard and also really look at data in a totally different way because it's all consolidated into one place. It could be a real source of truth for us. In the past, I've worked with a lot of different EHR programs. I started off in my first medical director job with Meditech was an installation they did while I was there. And so we went from T-sheet systems and the ED to Meditech. And that was one of the ways I got really interested in informatics was how do we do this? Because at the time there was a lot of like very slow clicking and latency and that type of thing. You take a very busy ED that was working on T-sheets with very minimal required documentation and transition that. So we had to just look at what was out there at the time, and Dragon was available. So we created macros and templates and order sets. And I actually got a download from the pharmacy, give me a list of all the medications we use. And they use their own system to download that. Lab information systems gave me the same thing. And we kind of just reverse engineered it so that we built protocols and order sets and groupings for 80/20 with that and put it together. And so I thought that was a very interesting exercise. But I've used Allscripts, I've used MedHost, I've used probably 10 different over time, and Cerner as well.
Yeah, yeah, all of them. uh, so I'm super passionate about training because originally, when I started with the Department of Defense, they were being forced to use this EHR and it wasn't made for them. Like it was just this generic system. And then over time, obviously things have improved. There's been optimization, there's customization, et cetera. But what I've seen working with so many different hospitals or so many different organizations is that there has been this lack of training. Have you experienced that in and of yourself of your organizations or how are you evolving so quickly and hitting on so many amazing things and yet keeping up with your team, your clinical team, your professional team, and especially all the hats that you're managing? How is learning and development and training deployed in your organization, not only today, but how do you see it in the future?
Yeah, that's a great question because, I do think that even though I think we have a really good program, most clinicians, most of our bedside users don't have any kind of inkling about the potential of what they can do to personalize and function within the EHR systems. And not just within the EHR, but with all the technology we interact with on a daily basis, to be honest now. It's like they know enough to get by, but not really what can really turn it into something that's like a new asset, something that amplifies their care. So what we do is for Epic specifically, we have a group called Epic Academy, and we have relationships with various groups. So, we have groups that are focused specifically on pharmacy and training for them, or respiratory therapy or nursing. And then on the physician side, it's more about focusing with particular specialties, so our service lines. And then we also have a regionally based system so that, like you said, care is not the same everywhere. And so if we're thinking about a standard, but it has to have some flexibility within that framework because care out in rural Mississippi is not going to look like what it looks like in inner city New Orleans. And so having someone that's able to go and not only, do the due diligence of what's new in an upgrade, the picture's going to be over here and not over here, and this is how you click a button, but also tell me about what that pebble in your shoe is today and let me help you to design a solution for that. I think it's a really important and meaningful way to go about it. In the future, what I expect is we will still have a human connection to be able to do that, but not just having a splash pop up here and there within your EHR, but truly having a conversational AI companion or agentic solution to be able to ask questions to and troubleshoot in real time. You don't have to dig up that paperwork that you have in your email somewhere or go find something posted behind a computer or what is the phone number for pharmacy. Those types of things I think are going to become a lot easier, and that's part of what's exciting about I think what we're seeing right now.
I agree. I really agree. Do you guys train in a classroom or do you have virtual training? Both?
We do both. Yeah, we do both. And then, we have annual, requirements, regulatory requirements. So for artificial intelligence right now, we're turning that into like and it's a very simple training program, but here's the pearls and pitfalls of what AI is. Here's what you need to double check. Here's how it works. And, so that's something that I think because of changing times, you need to turn in and bake into something that everyone does. But, we do have opportunities for people to gain expertise. We have a physician builder program. It's not just physicians now. We have APPs who do that. I think our first pharmacist is doing the program. I think we have about 80 credentialed people within that space. And so if you want to learn deeply, what your particular, workflow could be, we have those opportunities as well. Same thing with nursing. We have nursing informatics program. Many of our analysts in our IS division are clinicians, whether they be physical therapists or nurses. And so I think that really helps because they understand both sides. And then, there's particular things I think that come about that you just kind of have to have all hands on deck, right? And so I think you use those changes. So one example would be we changed from one type of thrombolytic for stroke therapy to a different one, and the doses are different. The way you give it is different. It's not a bolus and then a drip. It's just a push. And so then you kind of just say, okay, we got to get everybody in a room and do this. And it's usually a Zoom room because of the size and space that we have to work within. But we kind of say, all right, you got to join one of these things in the next 3 weeks, and we're gonna, make sure that we touch everybody.
Everything that you say is solving problems. And it's really inspiring, to be honest, Dr. Fort, because not everybody is sitting there. How do we solve this problem and move the needle forward? You either don't do anything, accept it, accept the reality of like, well, I just have to live with this. But there's so much improvement and there's so much that we can do. What is something, another big problem, or it doesn't even have to be a big problem, but what's your next problem that you want to solve in general?
It's a great question. I mean, I think the two big buckets of what we need to accomplish in the next phase is we're going to be facing unprecedented financial headwinds in healthcare in the next couple of years. And so we need to make sure that we're prudent about how we start to prepare for that. And so I think it comes into, like I said, two areas. One is access. And, I'm certain that that's something that comes up a lot in your conversations, but, just making sure that when patients want to come and see us, they have a way to do that and they can get there effectively. It can be incredibly challenging, like I said, to try to navigate the system, get to a website, call a scheduler, like what do you need? How do you get it? I think making sure that we don't put unnecessary barriers in place for people is going to be really key to that. I think part of that is also just rethinking the way that we deliver care. So part of what I think of with the virtual emergency department is it's rewiring ambulatory flow. It's creating an ambulatory flow center that mirrors kind of what we've done with our inpatient patient flow center, which helps us to figure out where patients go in beds and how they get from patient hospital A to hospital B, that type of thing. The thing that's missing is the transitional piece in the middle. And so I really think there's kind of this like very distinct need for partnering with people transitioning from episodic care to continuous care, volume based to value based, and really helping people get from point A to point B and not requiring our patients to do that all on their own. It's like, okay, you're discharged from the hospital. We've been doing, I think about this with like cardiac monitoring. Like if you don't really need a cardiac monitor, you shouldn't have it on, because what kind of message does that send a patient when they get discharged and they're like, well, now I don't have this thing. Like, what were you watching? And, so where does remote patient monitoring fit in? How do we start bringing in hospital at home programs? What kind of virtual care follow-up do we need to think about so that we can be smart about what we offer? I think right place, right care is really important too. And then, of course, near and dear to my heart is also making sure that we provide access to rural communities. I think that is often overlooked, especially as many smaller hospitals have shut down. It's a tremendous challenge, not just from a logistics perspective, but an emotional perspective for people from small rural communities to come into big cities and get their care. Like even parking in the garage is super scary for them. And so whenever you can avoid that and deliver that care locally, I think that's what we should do. And so that's what I'd like to build is a care traffic control center to rule them all that kind of makes all of that seamless and easy for not only our patients, but our caregivers and our staff.
That's awesome. A friend of mine has been doing telehealth for 10 or 15 years for the rural areas, offering OBGYN.
Mhm.
And it's just been amazing because she's been doing it forever to the, women that can't get in, or that can't get to a hospital or can't whatever. So it's neat to see the evolution and like where we are today. And yet this at the same time, there's still the need to make sure that everybody is cared for and has an opportunity to be cared for.
Yeah,
I
absolutely.
have absolutely loved listening to you. I could listen to you for another hour. I want to be sensitive on your time. To anybody listening from another hospital or another physician, or like I said, the students at the medical school, do you want to leave us with any final thoughts from Dr. Fort?
I think that, I think it I describe myself as a pragmatic optimist, and so I think it's easy to get kind of bogged down by some of the things that we hear in the media and what's being bantered around in terms of headwinds. But I think that we have unprecedented assistance with the emergence of some of our new technology. One of the most important things is to never forget about the people, though. And I think people need to be true to themselves about what they want to do, and then also really understand what that is in others and use that to be able to design processes that then you layer on technology to be effective. If you just plug technology into something broken and in a way people won't use it, or if you force them to do it, you'll never achieve what the potential is there. And so I really think understanding that intersection and making sure we capitalize on that synergy is the most important thing at this point. We're going to need the next generation to teach us how to do that because they grew up with, you know, smartphones and all those things.
Yeah, and that it's so funny. It's so true. Then we realize that we're not 20 anymore. And we're like, "Can you"
Yeah.
I'm like, "I'm becoming my mother." I'm
Yeah.
asking my children, "Can you show me how to do this?"
Okay. Yeah. And they can do it in like 2 seconds.
I know. It really is. And it's
It's clinical informatics. And they're like, no, mom.
exactly, exactly. Well, I will post your LinkedIn for people to contact you if they can, reach out to you if you don't mind. If anybody wants to
Absolutely.
further the discussion with you, I'll put that on this podcast as well. But thank you again for your time, for being here. And it was really insightful for me. So I just want to say thank you for your time and what you're doing, because it really is truly making a difference.
Thank you. Thank you for all that you do as well, April. Very nice to meet you.
Cheers. Every leader has a story, and every story reveals another piece of the bigger picture. What if the missing piece wasn't something you had to find, but something you were meant to become? Subscribe, share, and keep leading with intention. I'm April Reed, and I'll see you in the next conversation on The Missing Piece.